Assalamu alaikum and good evening, everyone. Welcome to one of the educational activities that we have been conducting over the last few years around Stemi care and Stemi management, ST elevation myocardial infarction. The group within the Emirate Cardiac Society that is interested in STEMI care and STEMI management have been putting a lot of effort to put such an activities together to share experience and improve the knowledge around the management of STEMI. Tonight, we have a rich program. It's a case-based program, and we have a diversity of faculty that is going to share with us their experience tonight. The focus of the meeting, we thought of changing compared to last year and bring some of the dilemmas and the controversies and the challenges in the area of STEMI. Those challenges and controversies can be in the diagnosis, they can be in the STEMI transfers, and they can be in the cath lab and how to manage the patients in the CCU. So tonight we have as I said, a diversity of faculty from UAE and also from the States. First, we have Dr. Samir Mehta. Dr. Samir is an intervention cardiologist based in Miami, Florida. He is a associate professor of medicine and chief intervention cardiology and president of the American Heart Association in Miami. He did his internal medicine, cardiology, and intervention cardiology training in New York and got an MBA from the University of Miami. He has a lot of expertise and experience in the field of door-to-balloon initiatives when it comes to STEMI intervention. And he participated and created a large number of STEMI networks internationally, in more than 20 countries. He's also a course director of Lumen Global Symposium, a premier AMI subject-centric annual meeting. And he is an author of 3 textbooks of STEMI interventions. So he's going to be our host tonight. We also have our colleagues from UAE, Dr. Ronnie Shantouf. Ronnie is a consultant intervention cardiologist at Cleveland Clinic, Abu Dhabi. We have also Dr. Pier Francesco Corvo. Dr. Corvo is an intervention cardiologist at SKSH in Ras Al Khaimah. And we have Dr. and Professor Abdullah Shihab, is a very close colleague and a board member of the Emirate Cardiac Society and an intervention cardiologist from Al Ain. And also Dr. Kamil Valaba. Dr. Kamil brings also the diversity of emergency physician perspective into the group. And he practices the chair and head of emergency at SKMCA in Ajman. So we'll move ahead with the program and with Dr. Samir Mehta. Dr. Samir is going to share with us a 20-minute presentation. Following that, we will go to the cases and we will have a discussion panel around the cases. At the end, of course, if you have any questions or answers, please, Dr. Mehta, you can share your presentation. For our colleagues, the attendees, please, if you have any questions or points you want to bring, please put it in the Q&A area, and we'll do our best to bring it up and share it with the panel group here. So, Dr. Mehta, please.
Dr. Al-Zubaydi, thank you so much for your kind introduction. Congratulations for putting on this remarkable course It is extremely relevant, and most of all also for accumulating a very talented faculty. As you have very eloquently mentioned, the discussions will be based, at least my presentation, on two aspects, both the process and the procedure. It is important to identify these separately because one does not go without the other. A procedure has to be done elegantly, but it has to be also shared with a combined effort of numerous people, and you have been very diligent in including an emergency room physician. We all have to work together as a team to improve the process. Without having an elegant process, there is nothing a procedure can accommodate. And I will lean also on my doing the Lumen Global Meeting in Dubai in 2013 to share with some of my observations. So once again, congratulations. And this is what we are going to be sharing in our presentation this morning.
Thank you.
Will my slides seem to be frozen? Okay, got it. So this is, as it was mentioned by the chairperson, it has been a distinct pleasure to create STEMI networks in many countries, a lot of them also involving telemedicine. However, more than anything, this has been my most privileged personal journey. As to last night, here was a case at 3:41 in the night last night. This has brought my personal numbers to 2017 short door-to-balloon interventions, and probably having the distinction of being the only physician probably in the world who does a STEMI-only practice. Majority of these procedures were performed between midnight to 5 in the morning. So with this, I sincerely and truthfully believe that I have earned your respect and the capital that if I tell anybody to run at 3 in the night, please trust me, that is what I have done for 21 years. A lot of these patients were without any insurance, which basically means you will save a life, but you will not get reimbursed. Door to balloon times have been coming down. Now the systems have become so good that I really do not take much credit. And this is precisely the message to provide to the Emirates Society. It is so important to get the process right. Once you're able to get the process right, the patient presents early, the management of the case is simpler, the lesion is less complex, the thrombus that is often present is more easily to treat. So in every possible way, every aspect, every component, from the patients recognizing the symptoms to the ambulance to the emergency room, everything has to be done to improve the process. Now, this is a lot of useful presentation for you. Experience which we have found, this was published in the Indian Heart Journal. Some of the lessons which we have learned, what happens in several developing countries. Now, the UAE in many cases is a very developed country in many ways, yet it has some characteristics which we found in India, that there are all sorts of system delays and barriers. These could be related to the patient, to the insurance or the payers, transport, probably the most important, individually to the hospital because they need to have precise teamwork, to an individual physician who has to be both available and an expert, and of course, some barriers in technology. So in trying to combine both the process and the procedural aspects, I have created for you, Mr. Chairman, the list of dilemmas, which I think is exactly what you want to use as a focus to share today. So there are what I call low-hanging opportunities, something mid-hanging, and then the final high-level dilemmas and challenges. What are the low-hanging? To achieve door-to-balloon times, to manage the thrombus, Is there any role of preventative STEMI? And we'll talk about the complete trial so that you get the message. In the mid segment, unless you're able to improve the pre-hospital management, there really is no justification to most institutions doing 24/7 STEMI. There is going to be a burgeoning role of telemedicine. How exactly do you bypass the emergency room? 27% of our patients now go straight from the ambulance to the catheterization laboratory. And as you become more and more elegant, we have discovered almost in every city and country where Lumen Foundation created a STEMI network that there are centers of excellence. I know in the UAE and within the people who are represented today, including from the Mayo Clinic, there are absolute centers of excellence in so many areas in the UAE. What should be their goal? They should, at the moment, immediately start looking at emergency room bypass. When you're able to do it, on an average, we shave off 21 minutes to the door to balloon time. Legislation, because it will come into play more in the United States, in the Americas and EU, but also going to be relevant in parts of the world. Management of cardiogenic shock, despite so many gains, is still very challenging. Gender issues are one of the most critical elements which we need to understand. And finally, unless you educate the patient, nothing is achieved. So with this, let's continue, get our basket. Let's try to solve out some of these dilemmas and the challenges, and let's get rid of these issues. So let's proceed with the low-hanging fruit, door to balloon time. Door to balloon time used to be a massive issue before. At the moment, it is not much of a challenge, and it's not much of a challenge because the system has become much better. You need to work as a team. And once you're able to work in the team, and I will show you many practical ways how we are able to reduce door to balloon time. Next one is the managing of thrombus. Now we have changed gear from the process directly to the procedure. A STEMI procedure will test the elegance and the maturity of an interventional cardiologist. There are often times you will not even have a clear STEMI lesion. I know one of the presentation today is going to talk about it. It is difficult sometimes, not impossible, but you could even have more than one culprit lesions. I have always believed that if there is an acute MI, just by the pathophysiology, whether angiographically apparent or not, there is going to be thrombus. So I have created a strategy, and this is what I have followed for almost 1,600 consecutive cases over 14 years. I do it a selective thrombus management strategy. If there is little or no thrombus, you can direct stent. If there is some thrombus, aspiration works very nicely. And in cases where you have got dense thrombus in large vessels, there is a role of angiojet or mechanical thrombectomy. You must understand that thrombus by itself and almost everything we do in a STEMI creates migration and distal embolization. And there is a use and purpose of using intracoronary vasodilators, which I am going to demonstrate to you here. So here is a patient with STEMI. You cross the lesion with the wire, and even with the crossage of the lesion with the wire, this is what happens, that there is some thrombus which migrates and you start losing some of the branches. What if you then put in a balloon, which I try to tell people not to use it and better to use thrombectomy? This is what a balloon would do. You even have more distal embolization. Finally, when you put in a coronary stent, which is the way to proceed with these, there is further distal embolization. So almost everything which we are doing during a STEMI causes the thrombus, which is often present, to go distally. How do you tackle it? You use intracoronary nitroprusside. In the first almost 500 cases of my STEMI interventions, I was using what I used to at that time consider very frightening doses of nitroprusside because it almost always causes hypotension. I would use 50 to 100 mics of nitroprusside and see its benefit in that it started causing distal vasodilatation. You have to realize that at the end of the day, to have an artery open with TIMI flow, but not to have myocardial perfusion is really of no benefit, because you need to get perfusion to the distal aspect of the myocardium that has been occluded. In the last almost 600 cases, my mean dose is now up to 500 mics, and this is what it does. It causes profound distal vasodilatation. Now, of course, there is hypotension. I almost always use intracoronary high dose nitroprusside in 50 micrograms boluses and follow it up with intravenous norepinephrine, and you are able to achieve both a balance, adequate blood pressure, and profound distal vasodilatation. Once again, what you're trying to achieve is both TIMI grade flow and myocardial perfusion. Let's change gears and go on to the aspect of is there a purpose of doing any preventative STEMI? This was the trial which put us all thinking into it, that look, are you able to take care of lesions before they become that severe? And this was all sorted out with the most elegant, a beautifully performed, complete trial, which put everything into rest. We understand today that you need to achieve a complete revascularization, whether during the STEM intervention or bring the patient electively, and you're able to achieve excellent results. What exactly are some other process methods of decreasing door to balloon times? Let us look at pre-hospital management. This is what is the experience of the Lumen Foundation and the Lumen Global Meeting. When I started this in 2001 and 2002, my door to balloon times used to exceed 150 to 200 minutes, which is what you are experiencing in several of your centers. Now, I have been doing angioplasty for 32 years. My skills were the same 15 years and now. So what improved? Our pre-hospital care. Diagnosing the patient early, getting the ambulance, making an accurate diagnosis, getting him to the emergency room, and bypassing it. Pre-hospital management is the way to go. That is how you're able to decrease your door to balloon time. What about the role of telemedicine? I think it is relevant in so many parts of the world, including in the UAE. Now, this is a real picture from Sao Paulo. This is not a photo shot which has been done. There are so many disparities. What you're able to see in the poorer parts of the world often intermingles with very wealthy places. One of the very elegant ways to eliminate disparities is with the use of telemedicine. This is one of our formative paper, A Tale of Two Cities. At the moment, this is a recent publication I presented at the American College of Cardiology. The Latin telemedicine program, which I created about 12 years ago, now provides an umbrella of protection for 100 million patients in Colombia, Brazil, Mexico, and Argentina. It is absolutely possible, Mr. Chairman, that this could be replicated in so many parts of the UAE. This is even a more elegant system, which I modeled after the Latin program. It is now known as the Rahat Angioplasty Telemedicine Guided System in India's biggest state, which has a population of 65 million people, and we are able to employ a telemedicine guided strategy, once again demonstrating exactly that this is the way to help less developed countries like in parts of Africa, parts of Southeast Asia, and even in the Middle East. Let's proceed into demonstrating to you what I mentioned about the ED bypass. This is how it is demonstrated. A patient comes, STEMI has been diagnosed, the EKG has been seen by the emergency room, whether it has been faxed or used by telemedicine. There is absolutely no purpose of a patient to start in the emergency room. A quick eyeball by the emergency physician to see that the patient is stable, the key being not to take the patient off the gurney and move him on the stretcher straight to the cardiac catheterization laboratory, easily eliminates 20 minutes, and this is what I think you should practice more and more. Furthermore, it is my belief, particularly in parts of the world where I have gone and established STEMI networks, that almost entirely the caliber of your success is dependent on your ambulance care. The more efforts are made, and it is not only the physical availability of an ambulance, but even the training of the paramedics, which is critical. Let's continue to make changes. Legislation. In parts of the world, it is extremely important. As an example, you need to have a most perfect total system of care approach, a STEMI network, which includes a regional center, a smaller center, and written guidelines, and an ambulance system, which is absolutely mandated. So even if a patient presents to a non-STEMI center, you're able to use the perfect triage. Now, you must understand that a lot of my work has been done in developing countries which have very effective methods of using pharmaco-invasive management. Several of our illustrated cases today will talk about it. In particular, in parts of the UAE, there is still a large relevance of it. You have to realize that thrombolytic therapy given to the right patient presenting very early is almost as effective. You simply need to have a very balanced, a very specific program how you are going to be using the use of pharmaco-invasive management. Let's continue to make difference. Cardiogenic shock. What you need to understand is being a reversal completely in our thinking and our management. Initially, the feeling used to be that this is in two areas of multivessel disease and cardiogenic shock, and I'll take a moment to explain the difference. When I started the Lumen Global work 20 years ago and 15 years ago, the thought process was when a patient comes to you with cardiogenic shock, you treat both the infarct-related vessel as well as the other significant disease, no more. The work of so many people, particularly out of Europe, has now demonstrated convincingly that you need to focus mainly on the culprit and you are able to do the rest later. In case of the multivessel disease, our approach initially used to be culprit only. Now, as the complete trial shows, that once you have done with that, subsequently, probably in the same hospitalization, you take care of the additional disease. Major change in this, but the take-home message for you, when a patient comes to you with cardiogenic shock, no longer do you need to chase all the vessels. Go ahead with the culprit lesion and manage the patient now. The other development which has happened, I know in parts of Asia and the Middle East, now you have the Impella catheter, left ventricular support also is demonstrating. Unfortunately, it is a very expensive technology, but its relevance has been demonstrated clinically. A much more prudent issue, something which happens almost every day, is what is happening with our women. This is a meta-analysis which Dr. Alexandra Lansky from Yale and I collaborated recently using data from almost 750,000 patients, where we understand that there are all sorts of barriers and outcome in women are not as good as they should be. It is absolutely a matter which should bother our conscience that the care which we are providing to our mothers and sisters, particularly in parts of Asia, even in parts of Middle East, it is based and it is slowed by so many barriers, which could be cultural, personal, religious, social, clinical, and financial. This is one of the biggest challenges, one of the biggest opportunities which we need to capture is to remove the barriers and the difference in the care in gender. My last aspect relates to a patient, and I will cite an example which will illustrate the issue. Patients who are diabetics often will have no symptoms. Women will have confusing symptoms. Elderly will have sometimes no symptoms or atypical symptoms. I have taken care of 3 interventional cardiologists and done their STEMI intervention. Even they could not diagnose. There is no point me and my team driving at 100 miles an hour at 3 in the night when the patient was having chest pain and he did not recognize. The role of patient education is so critical, and there are all sorts of methodology and techniques how we are able to do it. As an example, you have to start approaching patient education and STEMI intervention, not the job at an individual hospital, but as a public health issue. Once we use a public health issue, our stakeholders are so important. It is the family physician who is the gatekeeper. It is the cardiologist who balances interventional cardiology, STEMI interventions with prudent risk management strategies and moderation of lifestyle and adequate preventative measures, which are so critical. It is the interventional cardiologist who I insist needs to be both skilled, mature, and be available. It has to be the hospital which has to provide excellence in the ambulance system, emergency room, and in the cardiac catheterization laboratory. The role of the media is so important, and I am so delighted that under the chairmanship of the Emirate Society, now you're having tremendous amount of media education. The role of patient is so important because unless you learn to recognize the symptoms, there is no point, you will not be able to achieve the benefit. And of course, our politicians and leaders should help us establish systems of excellence. So with this, may I take you, Mr. Chairman, and give you a peek into the future. Out of the 10 dilemmas I have told you, I indicate patient education as possibly the most important. Maybe it has to do with my leading the American Heart Association in Florida. Let me show you what is happening. We are trusting too much of these doubts, and here is what I have been working on, is creating a self-administered, artificial intelligence guided, a single lead STEMI detector for a patient. It can be now mounted on an iPhone, it can be on the Apple Watch, it can be in the form of a ring which you put across the chest, it could be on a patch. 97% accuracy, you can detect your own STEMI. This is a paper I have recently presented, giving a powerful tool for patients to self-diagnose, and that is what initiates the STEMI process. With that, Mr. Chairman, here are my humble conclusions to your magnificent efforts which you are doing in chairing this extremely important initiative for saving lives in the UAE. So my first conclusion is, in my opinion, the biggest achievement in cardiovascular disease over the last 2 decades has been the reduction of mortality with door-to-balloon initiatives. However, this is not happening across the world, and committees such as yours can help restore the balance and take the advantages to all parts of the world. Now, the UAE, I realized in 2013 when I did the Lumen Global meeting, has the intellect and the firepower to bring forth innovative solutions. And Mr. Chairman, I am absolutely convinced that you are doing it in the most beneficial way. You need to get all the cardiologists working together, the society getting together. You are so powerful in your footprints there. Get the support from the government and the political leaders, and I am absolutely sure that you can create absolutely a world-class system there. And with that, I conclude my note. It has been an absolute pleasure interacting with you, and my best wishes to you for your further engagement.
Thank you, Dr. Mehta. That's great. And, it's a huge topic, but you highlighted most of the challenges from the patient all the way to, the challenges and regulations and setting up, a whole network. I'm sure there's a lot of discussion and questions and answers that's going to happen, and we'll get from our colleagues in relation to what you shared with us. Now I would like to move to our faculty members who are going to present cases that demonstrate dilemmas in STEMI care. And we thought of starting with one of our colleagues, Dr. Kamel Valaba, who's the chair of emergency department at SKMCA in Ajman. I got the pleasure to work with Dr. Kamel and the team in the Northern Emirate over the last 8 months on STEMI care, and with the teamwork did a tremendous difference over the last months, and also it demonstrates the importance that Dr. Mehta highlighted of the emergency department and pre-cath lab care of STEMI, which is which makes a lot of difference when it comes to the outcome, specifically mortality and shortening the door to balloon time of patients. So Dr. Kamel, please go ahead.
Thank you so much, Dr. Abdul Majid, for that introduction, and a fantastic talk, Dr. Mehta. I really enjoyed that. So good evening, everyone. It's an absolute pleasure to join you for this webinar and to be a part of an incredible group of speakers this evening. A huge shout out once again to the Emirates Cardiac Society, Dr. Abdul Majid, and our sponsors for extending this invitation to me. My name is Kamel Valab. I'm a South African consultant emergency physician, and I'm currently working in and managing the emergency department at SKMCA in Ajman. So I want to start off with the case. So whilst I was on shift in the ED on the 1st of October 2018, at around 3 p.m., I received this ECG via WhatsApp from my wife, who's also a physician, and she was in Cape Town, South Africa at the time. So the history was quite concerning. We had a 69-year-old female, previously well, with well-controlled hypertension, no prior history of ischemic heart disease. The patient was experiencing retrosternal crushing chest pain radiating to the shoulder with associated nausea and lightheadedness. The pain had been stuttering on and off since midnight, and this ECG was recorded at the rooms of a family physician that was consulted. So this ECG is quite clear-cut. It's diagnostic. It's an anterior STEMI. EMS was contacted immediately on ECG review and had still not responded 30 minutes later, despite 3 follow-up calls. Apparently, no ambulances were available in the area. The patient was then transported to a hospital with the family's private vehicle to the referral hospital, which is PCI capable, which is less than 10 kilometers away, and arrived in triage in the emergency department at 4:05 p.m., 1 hour and 15 minutes after the ECG was recorded. 1 hour later, she was still sitting in triage and finally managed to get onto a hospital stretcher at 6:11 p.m., more than 2 hours after arriving in the emergency department of the hospital. She was assessed with a repeat ECG and was simply told that she had a completed anterior infarct. At that point, the patient was pain-free and otherwise stable. Cardiology was consulted, and they arrived an hour later and stated that no beds were available in their unit and that this was a completed infarct that did not require any emergency intervention. The family made the decision to transfer the patient to a private hospital, where she was immediately to the cath lab and found to have a 95% occlusion of a mid-LAD. She was successfully stented 11 hours after the initial ECG. So the focus of that and my talk today will not be on any clinical dilemmas, but some of the systemic and logistic challenges preventing patients from receiving optimal STEMI care, and how we, as part of a system, went about addressing these gaps and deficiencies that were hindering patients from receiving timely primary PCI. Although this case was from South Africa, it highlights systemic issues potentially prevalent across the world, as our previous speaker has mentioned. I will reflect on our experience over the last couple of months as part of the Northern Emirates STEMI Collaborative, aiming to improve STEMI care in Ajman and the region of the Northern Emirates. So this is where I work. This is the emergency department at Sheikh Khalifa Medical City, Ajman. For those of you that don't know Ajman, it's the smallest but most densely populated emirate in the UAE. And our hospital covers a catchment area of roughly 500,000 people. Our ED visits exceeded over 70,000 people pre-pandemic, and we routinely continue to manage a high burden of both acute and chronic cardiovascular disease. We attend to a significant number of STEMI cases at SKMCA. In 2020 alone, we saw over 150 cases. And prior to the webinar starting, I was chatting to Dr. Abdul Majid to tell him that up to date, we've seen about 58 cases this year. So there is a tangible sense that the number of STEMI cases have been increasing over the last couple of months. SKMC, however, does not have a cath lab, and our STEMI patients are referred to PCI-capable referral facilities in the surrounding Emirates. So geographically speaking, my hospital is located right here, the green dot, and it's actually situated in between the two PCI-capable government hospitals in the Emirates of Ras Al Khaimah up north and Sharjah down south. And both these PCI referral hospitals are within 15 to 35 minutes driving distance. So the case that I highlighted essentially highlights all the elements at play in a system from the time a patient experiences symptoms till definitive treatment. The clock starts essentially as soon as the patient first experiences symptoms. Now, prior to our initiation of the collaborative, we presumed our patients were receiving optimal STEMI care. The ED was quite proficient at diagnosing STEMIs. We had no issues with that. We contacted the medical team early. Everyone gave each other high fives and we thought we'd done a good job. But patients were then being discussed by the medical team with the PCI referral hospitals and then transferred for PCI. And if they were not accepted, mainly due to bed availability issues, they were often lysed at our facility, admitted, and then transferred the next day if possible, a pharmacoinvasive strategy. A very small percentage of patients received fibrinolysis exclusively as their reperfusion strategy. So the STEMI Collaborative Initiative was born in late August 2020 under the leadership and guidance of Dr. Abdul Majid, and together with colleagues from hospitals in our network in Al Quwain and in Ras Al Khaimah, and more recently with smaller referring facilities in Ras Al Khaimah, we have worked together over the last 8 months to improve STEMI care in the Northern Emirates, with the main goal of ensuring that all STEMI patients have access to primary PCI in a timely fashion. We've done this with the mindset of a STEMI systems of care approach, with the aim of improving a collection of integrating processes and pathways to identify and treat a patient with a STEMI. Within our own facilities, we've had the opportunity to evaluate our processes, review the referral and transfer paperwork, evaluate data, we measure specific time metrics, and we do daily reviews of all these metrics and have weekly meetings to ensure that we're constantly looking for opportunities to innovate, improve, and evolve our processes and pathways. So optimal outcomes for STEMI care can be achieved by strengthening and optimizing all the elements in the context of a system of STEMI care: the patient, EMS, the ED, and the referral hospital. So when we initiated this, we gathered multiple stakeholders and we included emergency physicians, cardiologists, interventionalists, chief medical officers, representatives from quality that all committed to the collective vision. We evaluated our systems and our individual facility resources, and we started collecting the data, mapping out processes and identifying obstacles. I think for me, the CMO involvement was absolutely critical in our decision-making. One of the early priorities was tackling this no bed availability problem. And this became literally a non-issue within the first few meetings, with unconditional acceptance of all STEMI patients by the designated PCI center, irrespective of bed availability or insurance. We created unified protocols and pathways to ensure a consistent approach to management and easy access to the on-call interventionalist. A hotline was created, allowing us easy access to communicate with the cardiologist 24/7, and we set up a Microsoft Teams platform to transmit ECGs. And then we routinely monitor performance weekly with real-time quality improvement. Some of our most recent initiatives have been to initiate some educational activities to teach physicians about subtle findings of occlusion MIs that require primary PCI, and that's ongoing. And currently conversations are continuing with EMS to transfer patients directly to PCI-capable centers. So I must admit that I never really bothered much about the referral process prior to our collaborative. I mean, through the lens of an emergency physician, I was just pleased that we were diagnosing STEMIs timeously and alerting the medical team rapidly. But we as a department chose not to see our medical colleagues getting on the phone, discussing the case, being frustrated that they can't send a patient across to a PCI center. We didn't realize the multiple things that needed to take place before the patient finally got onto the ambulance and departed the hospital. All our pathways were fragmented, they were inconsistent. Patients were sometimes transferred to Al-Qasimi Hospital, sometimes to Sheikh Khalifa Specialty Hospital, and even to some private facilities. And our colleagues in medicine initiated this referral. And sometimes our in-house cardiologists need to be contacted to make the referral. So whilst the majority of patients eventually got to the cath lab for primary PCI, we had no idea what their outcomes were. Some STEMI patients were treated with a pharmacoinvasive strategy due to bed unavailability at the referral hospitals. So we needed some sort of data just to understand where we were and to judge what we're doing as a facility. And we started by looking at the first 2 quarters of 2020 and were astounded to find that our door in, door out time for transferring a patient was 83 minutes. So we set about looking at the processes to try and identify these opportunities to improve. And what I did initially was I mapped out the entire process once a patient walked in to the department and was diagnosed with a STEMI or STEMI equivalent, and was truly amazed by the tangled mess of multiple processes and microprocesses that were required actually to get the patient onto the ambulance. Really, really convoluted process. I'm not going to walk you through the slide, but essentially it needed multiple conversations with multiple people, and once accepted, further conversations with multiple people prior to the patient leaving. So took out the axe, eliminated all the redundant and unnecessary steps, and surprisingly, we were able to eliminate quite a bit of the redundancy in the pathway, and we achieved a much more streamlined and simple referral process. And what this means is that once a patient walks into our door and is diagnosed with a STEMI or STEMI equivalent, we run an in-house STEMI alert within our department. And this basically ensures that all relevant people involved in the care and the referral of STEMI patients are notified immediately on recognition of a STEMI. And our goal is to try and get these patients out of the door within 30 minutes. So just a little bit more about our STEMI alert, just to tell you, previously everything seemed to happen in series. So, one step would happen only after a previous step was completed. But what our STEMI alert does is ensures that multiple things happen in parallel once we identify a patient with a STEMI or STEMI equivalent. And the emergency physician rapidly calls the STEMI hotline, which is 24/7. The ECG is immediately shared with the on-call cardiologist on MS Teams, and the patient gets accepted and the patient is loaded onto the ambulance. When the in-house STEMI alert is called, the ambulance is waiting on deck with the stretcher, the transfer physician and the transfer nurse is on hand. So these are the things that shave off minutes and that have helped us reduce our door in, door out time. We've also protocolized the immediate medical management of STEMIs to ensure consistent administration of medication prior to transfer. So in summary, this initiative has resulted in quite a streamlined process. We've eliminated all the redundancy in the process. We've taken away all the unnecessary paperwork that was just really weighing down on us. And the creation of a single phone number for referral and a standardized referral form between the facilities. Bed availability is no longer a rate limiting step, and MS Teams has been set up as the platform for communication. And we often get feedback from the cardiologists with regards to the patients that we send, just to close the loop. And the results speak for themselves. I mean, our improvement over time has been astounding. We started this off in August, and our door in, door out time averaged 101 minutes, and we got down to around 37 minutes in November. And remember, we include all cases, so even cases that are cardiac arrests that may have needed to be stabilized before referral, and patients that potentially needed to be intubated and stabilized beforehand. So these kind of skew the door in, door out times, but to date, thus far in March, we've achieved our best door in, door out times for the patients that we've sent across, hitting 28 minutes, which is within our target of 30 minutes. And this has also translated to improved door to balloon times, and consistently, since November, we've met the 120-minute target or even less for door to balloon. In fact, in March, we at an average of 82 minutes now, which is absolutely fantastic. So to conclude the case, the patient that I presented was my mother, who had a STEMI in October 2018. But I'm happy to report that she's doing well, alhamdulillah. I may not have had a chance to impact on her care directly, but hopefully all our combined and continuing initiatives in the Northern Emirates will leave a footprint that ensures that all STEMI patients have access to timely primary PCI. Thank you.
Thank you, Kamel. Thank you so much. Very touchy case. You know, I mean, this work, it just, you know, it touches everyone. I'm sure it touches, you know, our families, it touches the community, and, you know, a little impact on any of these patients definitely will translate into, you know, preventing a disability or preventing death. You know, I know, Kamel, you went through a lot of work over the last few months. I would leave to the panelists to ask if they have any questions before we move to Dr. Ronnie. Dr. Samir, Ronnie, Carvo, Abdullah, any questions for Dr. Kamel?
May I begin the conversation?
Please, go ahead.
First of all, Dr. Wallab, congratulations. Such a beautiful case to show exactly the challenges. And I congratulate you on the very thoughtful ways you have approached it, how you created the algorithm, identified exactly the challenges, and went about in a systematic way to eliminate all of them. I maintained in my initial presentation, it is the pre-hospital management which probably impacts the door to balloon time. And as I even admitted there, my skills are the same. The difference was the system improved, the process improved, and the result outcomes improved. Now, you have done so many things which are so very well thought out, and I will identify some of them because they require special mention and people do not intuitively think of it. They think of door to balloon time. Your emphasis as the first center on door in, door out balloon time is one of the most intelligent endeavors anybody could have had. Now, in the Latin telemedicine program, 275 centers, that is exactly what we used to have a strategy. I used to call it 3T. Telemedicine, triage, telemedicine, transfer. So that's exactly what you're doing. You're identifying them quickly and sending them out. So beautifully thought out, and good luck. Now, two other things you're doing right. One is that I think the emphasis you have on quality follow-up, quality assurance, or quality initiative, it is so important because that will continue to tell you where the problems are still there and you will be able to remove the bottlenecks. Your emphasis on having data is absolutely right, because without data, there is no way you're able to make. My recommendation is start using artificial intelligence with some of the data to help you guide and navigate with better results. Your emphasis on feedback is exactly right. That is one of the 6 initiatives which the American College of Cardiology has highlighted. So in my conclusion, Dr. Abdul Majid, I make a statement, which was my opening statement. Dr. Abdullah Shehab was there in 2013 at the Lumen Global Meeting. The UAE, in my mind, is an absolute mecca of opportunity, that in the entire Emirates, every patient can be done by primary PCI. You have the firepower, you have the muscle to do it, just the resolve is needed. Congratulations, Dr. Wallab.
Thank you so much for your feedback and your kind words, Dr. Samir.
Thanks, Samir. Thanks, Kamel. I think just because of the time, I know there's a lot of questions here, but I would keep it to the end. We'll just move to Dr. Ronnie Shantou from Cleveland Clinic, Abu Dhabi. Dr. Ronnie is an interventional cardiologist at Cleveland Clinic, Abu Dhabi, and he's going to share with us one of the dilemmas that he had in the cath lab, I think. Go ahead, Dr. Shanto. I think you're on mute, Rani.
Ronnie, are you on mute or no?
Can you hear me now?
Yeah, go ahead. Yes, you do. Yes, go ahead.
Okay. So I'm going to share a case of when I was a fellow. This is back in the United States. So I did my fellowship at a county hospital, very busy hospital, a lot of patients who were uninsured. A lot of patients would come in via the ambulance. We also had a lot of walk-ins. So this is a case of a 63-year-old male, South Asian male patient who presented with substernal chest pain on and off for about a week. It was followed by persistent chest pain for 3 days, which significantly increased on the day of presentation. He presented diaphoretic, nauseous, dizzy, stated he had worsening dyspnea on exertion on the day of presentation. He was also orthopnic. The patient actually brought himself to the ER as a walk-in around 9 a.m. and was not triaged till about 9:25. He had no other major medical history, no past surgical history. His family history was not contributory. ECG wasn't done until 9:43, which clearly showed a ST elevation, anterior lateral ST elevation with a right bundle pattern and also significant Q waves, indicating that this process has been going on for a while. His vitals were actually really important and his physical exam became very important. So he was tachycardic, hypotensive, was noted to be diaphoretic and cool to touch. He also had a harsh, loud 4 out of 6 whole systolic murmur throughout the precordium, loudest at the left mid lower sternal border. He had crackles 2/3 of the way up. His labs, he was noted to have an acute kidney injury, and also his liver function tests were elevated. So this is a patient who clearly presents with a late anterior STEMI with ongoing symptoms. He's hemodynamically unstable, and he clearly has signs of cardiogenic shock. This actually occurred at the same time as 2 other simultaneous cases, another STEMI and also a high-risk end STEMI requiring high-dose nitroglycerin. Patient was loaded in the cath lab with aspirin and clopidogrel. And so the decision was made, what do we do and do we take this patient to the lab? The patient eventually got to the lab at 10:20, given another STEMI case was being finished. Cath showed a non-dominant right, moderate disease in the circumflex system, and you can see a critical subtotal lesion in the anterior, the proximal LAD. You can see with the reduced flow, TIMI 1-2 flow. Now, because of the murmur, the fellow, we were highly concerned. The patient had a ventriculogram done, which showed a ventricular septal rupture. And you can see here in the multiple views, and you can see the contrast going from the LV to the RV and out the pulmonary artery. So do we PCI? Do we send the patient for emergent ventricular septal rupture repair plus CABG? We put them on mechanical support and delay revascularization. What's the best timing for such a situation? Also, the patient did receive clopidogrel. So this really called for an immediate heart team discussion. We called the surgeon into our lab, and I think this is one of these presentations where you need to have a coordinated care and management plan that involves your surgeon. And so we actually had a discussion in regards to what's the best approach. In our situation, it was felt that taking the patient emergently to the OR would have been very high risk And there's a large concern that the muscle would be very friable and difficult to repair. And for the patient clearly in cardiogenic shock to go to the OR would have been too high risk. Our surgeon was very comfortable operating on dual antiplatelet therapy. So a decision was made to fix the coronary and then support the patient, hemodynamically support the patient and try to push out the surgical date for the ventricular septal rupture repair. And if patient did deteriorate, they would go to the OR sooner. So the patient underwent PCI, one drug-eluting stent was placed, and a balloon pump was placed. Here you can see that clearly the patient was in florid heart failure. Transthoracic echo, clearly showing the large VSD from the LV to the RV. And so medical therapy, the patient received swan-based optimization of his hemodynamics. He continued to have a balloon pump until surgery time. He did develop a C. diff infection. LFTs, creatinine were able to normalize, and we had ongoing discussions with the cardiothoracic surgeon regarding the optimal timing for surgery. Day 7, the patient was taken to the OR as the patient started to show some signs of hemodynamic deterioration and a decision was made to take him to the OR. Intra-op TEE, again showing the ventricular septal rupture. The OR report noted that there was a small thrombus in the distal apex and a large defect in the mid to distal septum with necrotic tissue, which they were unable to hold the sutures, and thus a left-sided hemoshield patch was placed. He also had an aneurysm repair. So this is our post-op TE, intra-op TEE, status post-repair. Post-op care, by day 2, he was extubated. He had a long post-op course requiring titration of his volume status and of course treatment of his C. diff, and he did develop a hospital-acquired pneumonia. He was finally discharged home on day 24, which was post-op day 17. I followed him for the remainder of my fellowship, and he actually did quite well, NYHA class 2 with an EF of 40 to 45%. Just a quick slide in regards to ventricular septal rupture. So in the era of the reperfusion, the incidence was as high as 1 to 3%. In-hospital mortality, if they were surgically treated, was near 50%. And in-hospital mortality, if they were just medically treated, was near 100%. During the thrombolytic and the primary PCI era, we saw that the incidence has decreased with early revascularization or reperfusion. However, the mortality rates have been slightly overall similar. These are all small studies. So you see about a surgically treated patients with a 30 to 40% mortality and a medically treated patients with a near 100% mortality. It's important to keep in mind that there is some bias in these studies because the patients that are actually considered well enough to go to surgery may actually be biasing towards the surgical repair. Patients with mechanical complications such as a VSR have an extremely high mortality without definitive repair, and even with definitive repair, their mortality remains high. So I think a few take-home points. This patient was a walk-in, so we did lose time. There was a delay of care as opposed to being coming in with the EMS presentation. There needed to be a high index of suspicion for such a case, and I think patients that do present in shock or a high kill-up class, the consideration for mechanical complication has to be done. Late presenting AMIs should also keep our index of suspicion high, and of course, involve your surgeons early for decision-making. And as we noted, the impact of surgery is somewhat controversial, such as along with the timing. And of course, future discussions are open for discussion would have been things such as heart transplantation, ventricular assist devices, or higher mechanical supports. And if patients do survive the initial hospitalization in the first 30 days, they actually are likely to survive out to 1 year. Thank you very much.
Thank you, Ronnie. This is a great case. I mean, this case again highlights the the delay when there's the cases when there's a delay in STEMI presentation. Mechanical complication goes high, but well managed case and an excellent outcome. I don't know if there's any comments from our colleagues on the panel.
May I ask something directly?
Go ahead, Dr. Corvo.
How did the surgeon consider to wait 7 days? Which was the main concern that they decided to do? 7 days in this kind of rupture I think is very, very dangerous for the patient.
Well, I think the surgeon's concern, which I've heard from multiple surgeons, has always been that to be able to close the VSD is in the early stages of the MI, the myocardium is so friable that it's hard to actually suture the walls. And this is what creates the higher risk presentation, as opposed to if you can have the patients wait, you may have less friable myocardium that would allow a more complete repair. And this is what this is the concern with the studies, is that this is the bias in and of itself, is that the patients that get selected to go to surgery are somewhat more stable in and of themselves. And we don't have any true randomized trials comparing, of course. And so we're at the mercy of the observational studies that we do have.
And for this patient, the intra-aortic balloon pump was enough to support him for 7 days, or did you use any kind of other support, like, I don't know, any other medication?
Yeah, the intra-aortic balloon pump was able to support the patient. This is actually an old case. So this was back from 2011. The hospital did not have any higher mechanical support at the time. This was a county facility. This was the support that was available at the time.
Anyway, this is not the dilemma. This is a nightmare.
Well, yeah, definitely for the fellow that was in the ED.
I know we are under the pressure of time, but if there's any, pressing or, a good highlight, we would like to take it. Abdullah.
Just, I'd like to highlight here to Dr. Ronnie and Dr. Samir with us. You mentioned the pre-thrombolysis era. I think, if you look at the registry data, there are at least a third of the patients of Stemi not getting any kind of reperfusion. So we're still living that time. So it's not good.
True. That is true.
You have data from the Gulf, at least. I have it here.
Sure.
Thank you.
So we'll thank you, Ronnie. This is a great case. We'll move to Dr. Corvo, and we have another, I think, cath lab dilemma. So Corvo, please share your slides.
Yeah, sure. Considering given the time, I will try to shortage the time of my case. Sure.
We give some time for discussion.
Okay, good. So this is a case of 48 years old male. Is a known case of DM and hypertension presented with to the ED with typical chest pain started 2 hours before first medical contact. ECG was showing ST elevation in inferolateral leads with even ST elevation in anterior leads. The on-call cardiologist was contacted for direct transfer and urgent CAG and possible PCI. At the time of presentation, the Kilip class was the first. Loading dose of ticagrelor 180 and aspirin 300 with heparin 5,000 units was given just to shift the patient. So at this time, everyone can just decide which kind of diagnostic catheter use. So I was thinking that this patient was Indian and was left dominant. And considering the presentation ECG, I was thinking that maybe there is an occlusion of the proximal left circumflex involving even the first big obtuse marginal. But when I did the angio for the RCA, I found a fresh lesion, thrombotic lesion in the distal RCA. So I decided to do an angio even for the left, because I need to proceed for the PCI on the RCA. Just thinking that after the lesion, we will have a big posterolateral branch. But even the angio of the left was showing the occlusion, subocclusion, or anyway, total occlusion of the mid-LAD after the first diagonal branch. So at this point, which is the strategy to follow? Which is the infarct-related artery that we should consider? And after we will consider one of them, let's use wiring direct stenting, ballooning stenting, or thrombus aspiration. So what we used as a strategy was considering a thrombotic fresh lesion that we found in the distal RCA. RCA was considered as the culprit lesion. And the ST elevation in anterior maybe is just a new one, or is going on, is a chronic that is just going to the occlusion. So we started with the wiring of the distal RCA, the PDA, and we proceed with the direct stenting on the distal RCA and the mid RCA, where was even another region. The final result, sorry, it's not going, yes, the final result was very good. Even the big posterolateral branch was present with a Timi flow grade 3. What the guidelines suggest in this setting of patients? To treat the non-culprit lesion is not mandatory, is not suggested, and we should consider only to treat the non-culprit lesion if the patient is in cardiogenic shock. But this patient was really stable, and after treating the RCA, the patient was free from symptoms. So what to do? This is a common presentation. Should we consider it as a double infarcted artery, or we need to proceed for a staged PCI for LAD in the next days? So at this time, we consider the time of the procedure that was very short, and the LAD is always LAD, and the mid segment seems to be really short. So we proceed with the wiring even of the LAD, protecting the diagonal branch with the direct stenting of the mid LAD. We got a very good result even for LAD, and we need to consider that the LAD was giving even an inferior branch to the heart. The day after, the ultrasound done for this heart is showing that maybe the decision taken was the right decision, because the left ventricle, the ejection fraction was 40%, only showing the akinesia wall inferior base wall. This was the ACG 3 days after the PCI, and is really evident as the ST resolution of the inferior leads, even anterior leads, is totally complete. But is totally present, the Q wave in inferior leads, and even the R is not coming out as normal. What I need to share is even the concept that usually the operator has to consider for this procedure. The dose area product, that is the radiation risk for all this working with this kind of patient, the timing of the procedure, the radiation dose for patient, and the total contrast use. I mean, these are very important points to discuss when you are doing this setting of patient, where two unstable plaque or two totally occluded plaque, acute occluded plaque are present. So which are my take-home message? I think that interventional cardiology is not only the plumber of the heart, and any decision taken will affect the future of the patient. The decision maker has to consider the cost-effectiveness ratio to choose the best treatment for any different setting of patient. The real world sometimes is not completely matching the guidelines, and the experience of the operators is making the difference. Thank you.
Thank you, Corvo. That's an interesting case. And, you know, occasionally we see such cases where, you know, in the cath lab, you don't know which vessel to go after. I mean, when the culprit is very clear, things are easy, but when it's in such a case, it is a challenge. Any questions for Dr. Corvo from the team?
I have a few remarks, Dr. Abdulmajid. Dr. Corvo, excellent case. Fortunately, this dilemma is not something we see too often. So the less accomplished interventional cardiologist should just feel more comfortable that this is not something he's going to confront every day. Now, I think your decision to proceed with the LAD was right on. And, you know, he's a 48-year-old guy. So, you know, you can't leave the LAD, and both the results were elegant. I would have personally, I encourage you as well as everybody else in the audience to use doses of intracoronary vasodilators. Doesn't have to be only nitroprusside, verapamil, nicardipine, diltiazem. The larger, believe me, I can look back at 20 years of my STEMI work, and I can tell you that some of the most incredible things, particularly if you take a look at it, the persistence of the Q wave, that probably relates to some aspect of distal migration of the thrombus in the distal vessels. And now, would it have been completely taken care of by vasodilators? Maybe, maybe not, but give it a shot, and I think you may be all surprised. Now, the other good part of your presentation, I think that relates to the decision, how often we are going to be making a decision to take care of the additional lesion at the same setting. So I use my Mehta strategy there. What I insist is, before you are ever considering a second vessel, the first vessel result needs to be perfect, which means there has to be a relief of chest pain, ST segment resolution, TIMI grade 3 flow, and myocardial perfusion grade 3. The second criteria I always use to proceed with the first one is that the second case also should be technically simple. There is no point you've taken care of the culprit lesion and now you're doing a bifurcation, difficult thing. So if those criteria are there, I think you should proceed to the second lesion. But a very nicely done case, and so many things to learn from there.
Exactly.
Thanks, Samir. Question on the intracoronary. I mean, I received this on the panel, on the Q&A about intracoronary treatment, especially for slow flow and no flow. First is there any data? I know we don't have a lot of data on this, but it's our experience. And can you just highlight on that? And do you have a protocol that you follow? I know there's a different, we talked about the sodium nitrite, talked about verapamil and epinephrine. Do you have a specific protocol, or just use your own judgment for, according to the case?
Right. All excellent questions. The earliest data of demonstrating the use of intracoronary vasodilators and improvement in the myocardial perfusion rate comes from Mike Gibson's work. And although it has not emerged as a part of systematic guidelines, I think there is a lot of individual experiences which will demonstrate it. I do have a very clear protocol. The first protocol is to get the best possible result. Do not worry about the distal flow unless you have a perfect result with the stent. Then often in that case, I remove the wire, because the wire itself is a nidus of further thrombus. At that point, I'll give in 50 micrograms increments of nitroprusside. I have also used other agents, but my preferred is nitroprusside. Watch the blood pressure. If the blood pressure is okay, you can go to a next increment. And if not, you need to address the blood pressure, 50 mics. Also, again, the same dose of the norepinephrine.
Great. Thank you. Abdullah, do you have a question or thought or comment before you move to your case? I'll unmute you, Abdullah.
I'm fine.
Excellent. So great. I think this is a great case, Dr. Corvo, and we'll move to our last case and then the discussion.
Right. Okay. Thank you very much, Dr. Majid, everyone, all colleagues. It's nice to be the last, so we can remove things which is not relevant. So I kept few cases very short, again, just to keep within the time. Nothing relevant to this topic. Again, Dr. Samir, look, our patients are always young in this part of the world. 40 years old, no insurance. This is another dilemma. We get people no insured. And this patient was actually a young man, already treated for peptic ulcer, presented with some possibly inferior, could be right coronary, most likely could be left circumflex. We normally do radial. We used to go just for culprit at the beginning, but then we learn this, sometimes you make a mistake. So this patient we load, with the normal antiplatelets, again, with the high potent antiplatelets, which we done for this patient. So right coronary was mild disease, and left system, you can see, you can't believe it, very small left circumflex causing that inferior changes. Now, peptic ulcer, remember, no insurance, and I'm not sure able to afford any medication, this guy in long term. So I've, for a few years, actually, I've been, in addition to balloon, I've been drug-coated balloon. So this patient I've treated with ballooning first, normal as everyone does, wiring and ballooning. Then getting good results with the ballooning. So we went with the DCB here, which is again same size as what balloon we used, 2 by 15 dot coated balloon. That was a result. And I have a series of these, and again published. I mean, we go according to what published: acute coronary syndrome, DCB being tried, and results being similar to even some third generation stents. Another case, so this is after so we advise patient, at least you look at your lifestyle, try to stay away from smoking and all these things, what we do for every patient, and secondary prevention. So the second patient, even younger, again, 32 years old, 18 hours history, of chest pain on and off, arrived to us with this kind of changes, already established anterior segment. And again, young man, let's see what we're going to find. So left system looks okay, but look, proximal, very proximal, almost maybe including the left main. And then you have thrombotic at the end of the LAD. Is it a lesion there, or is it part of the thrombus there? We don't know. So again, balloon that, and not always easy to do that. You go to the wrong direction, you correct yourself. So I went with a balloon, trying to see if I can get anything. I did several ballooning there. You can see here with the second or third time balloon, then I had to go, because nothing coming out. That area was, so I had to go with aspiration device. And you look at this, at the end of that catheter, you can see a big thrombus that we brought it out. That's what, because I was not able to aspirate anything. And you can see in ballooning here, so I had to really spend some time to get that inflated. So really time is important. After that, again, this case, again, I use a DCB because again, a young man, and I'm not sure what's the future of this patient. And I was not sure about really at that time to deal with his, LAD disease, which may be coming to left. Again, I had to use a DCB here. Some of you disagree with me, but this was the case. So this was after a few weeks, came back with the chest pain. Now, troponin was negative, similar ECG as before. And look at the left system, nicely, beautifully, look at that, distal. This is a DCB effect and the DCB effect on the proximal. But what we found here, it's bridging. So this was missed maybe on the first visit. And again, this was DCB as well. So that's maybe another management of the milking of, or to do a DCB. Anyway, what we did in this patient, we did that because of the chest pain, we did IFR. IFR distal to the bridging was significant, 0.88. But proximal to that, it was perfect, it was 0.95. So this was like 6 weeks after that incident. So how should we manage this case with the bridging? And again, I've really DCB'd that. Will you do put a stent? Imaging will be important, we didn't do that. But we said, look, we go with the pharmacology for now. So this is another kind of dilemma. We don't know what to do with this patient. Another, I think, third thing is the patients who get pharmacoinvasive, what you said. And we are living nearby another country, which is Oman. Sometimes we get patient from there, thrombolized. So this patient actually was not that the case, was a case in here in our hospital. But our hospital, that cath lab was busy with another complicated case. So this patient was going to be delayed at least 3 hours. And so what do we do for this patient? We thrombolize this patient. And that was the results after that. You can see nice ECG result because you get the penetration. That's what you want. And then we did a pharmacoinvasive, we did angio. You can see the lesion are there, multiple lesions. So we can apply the total angioplasty for all these next day, which is very easy to do. So I think that this is the dilemma, as Dr. Samir mentioned. In UAE, I think Dr. Abdul Majid, after our primary PCI published in the Gulf, we found our door-to balloon is not bad, but in the right centers. But there are centers which are door-to balloon so bad, and there is no awareness. Dr. Abdul Majid, despite the administration job, he took over that, and he made it in his hospital nearby, and at least in Abu Dhabi. That primary PCI available. fibrinolysis still has got place as well. We can, as long as we can mix it in the right way, as Dr. Samir mentioned. And these are all the dilemmas which mentioned by all of you. Thank you very much.
Thanks, Abdullah. This is a great case. Now, I think the dilemma that we face here, and you highlighted in the first case, is the uninsured patients and those who cannot afford, the long-term healthcare support, and and especially we had challenges, especially with the old generation drug-eluting stents, which is a stent thrombosis, and the compliance with the drug-eluting, with the dual antiplatelet therapy for a longer term. And I don't know, what the panels think. If you're facing a patient, do you still consider a bare metal stent? Would you elect to go with the drug-eluting balloon to minimize the duration and the risk of stent thrombosis, because some of these patients cannot afford the long-term dual antiplatelet? I know some centers developed, I think in Spain, some sort of a rapid assessment of or a tool to tell if the patient is going to be compliant with the long-term drug-eluting, dual antiplatelet therapy or not. So I mean, this is open for discussion. I mean, this case just highlights that part, the compliance with the long-term dual antiplatelet therapy. Let's ask Samir. I mean, what do you think? And then maybe we'll ask Ronnie.
Well, Dr. Shihab, first of all, three beautiful cases, all done with wisdom, maturity, expertise. Not easy cases. They present different challenges. Now, the issue here regarding the two aspects which I think need to be addressed here. One is the care of the patient without insurance, and of course the use of bare metal stent. So the second is the easier one. I can help you understand. In a few rare situations where we had a patient clearly headed for surgery, or where we identified multi-vessel disease as an example. So one of the things I do, I think one of the first speakers in his first case identified it beautifully, that the first picture was taken of the RCA and the culprit was the proximal LAD. I think knowing a complete coronary anatomy before proceeding is one of the wiser decisions you make. Sometimes there is a big hurry, and I have created a little algorithm to make things work with very short door to balloon time. So if my presenting EKG is showing a culprit in the left system, particularly the LAD, I'll proceed straight with the guiding catheter and take care of the LAD lesion. If, however, the disease in the right coronary artery, I always take one picture of the left, because your whole management strategy changes. You have an ostial lesion of the LAD, you have a left main disease, a patient who might possibly. So in these cases, let's say you've got a patient presented with the large right coronary infarct, you've taken a picture which shows an ostial LAD or a left main, I will probably put in a bare metal stent, because in my mind, I'm thinking this patient is going to need surgery in the short outcome. Short of that, I think almost every patient is getting a drug-eluting stent. I think Dr. Shehab should present the data about the DCB. It is innovative, a very intelligent way to approach it. But we need to follow these patients and be sure that the initial gain is not lost by a higher restenosis rates. Those are my comments. I think if I was to give you 2 or 3 guiding some lessons which I have learned with the Lumen Foundation, working with almost 37 countries now, it is to have a firm belief in the power of primary PCI. If you continue to have a strategy which is absolutely directing patients to have a strategy of primary PCI, as a community, that is a very good idea, because what happens is, if there is ambiguity in it, then unfortunately the biggest problem happens, which is thrombolysis during the night, PCI during the day, and that is very unfortunate for our patient. As I have understood the entire structure of the UAE and your all sorts of clout, which I think you need to exploit here, I truly in my heart believe that the UAE can create a world-class system of primarily primary PCI. My last comment here is of relevance to all of you. When I started the Latin telemedicine program, it was in the city of Barranquilla in Colombia. Before we started, and this is also the importance of collecting data which Dr. Vallabh had mentioned, in the city of Barranquilla, 84% of the patients were self-transporting. After 5 years of doing the Latin program, people talk about it, how much door to balloon time did you improve? The statistic which we improved the most was 76% of the patients were now being transported by ambulance. So system-wide benefits which come from having a STEMI system of care will always help you.
I agree with you, Samir. I think, if you look at the UAE map and we look at the population, the areas that there's the population are located, probably more than 90% of the population are within a very close distance from a well-established, highly high-level cath lab service or a primary PCI service, all the way from the Northern Emirates, from Ras Al Khaimah, all the way down to Abu Dhabi. And we mapped it compared to the population. And I think, just to repeat your message, I strongly believe that in UAE, we do have a good access and easy access to the cath lab. The key is in the logistics, and the example showed by Dr. Kamel, needs to be done in the areas where there is challenges. But I think a lot of our colleagues in different areas in the country have covered a large number of the population. But still, there's a lot of lessons to learn and to enhance it. Now, there is a question I was going on or back to the door to balloon issue is, and maybe we'll ask Dr. Kamel for that. And I don't know if you have a comment, Samir, and that's the impact of COVID on the door to balloon time. And still we're in the epidemic, still we're seeing waves back and forth. But how did we and how are you handling it? I know also your hospital is one of the COVID hospitals in the area.
Yeah, thank you.
Is still there. Yeah.
Yes. Thank you for the question, Dr. Abdul Majid. I mean, it really hasn't changed much. I think, more from a patient perspective, patients may not present early enough because they may assume their symptoms may be due to COVID. So case in point was a patient that we had last week that was known with COVID, had come in with some chest pain and attributed all these symptoms purely to COVID. And then it was a very astute triage nurse that said, listen, this, anyone with chest pain should get a 12-lead ECG. He was in his mid-30s and had a massive anterior STEMI. So, it really doesn't change things we do from a diagnostic point of view, but maybe from a patient perspective, they may just attribute their symptoms purely to COVID. So a lot of education needs to be placed in that aspect of care. I think as well, maybe in terms of us referring, there may have been some initial hesitancy to take patients that may have COVID and STEMIs, but that seems to have gotten better over the last few weeks.
Dr. Abdul Majid, since this is such a relevant topic emerging in so many countries and which is going to stay with us for a lot more time, I think I'll offer some tricks which we have learned. The first part is initially when the crisis occurred, there was so much concern for exposure of the team that we started leaning back into trying thrombolytic therapy, which we have not done in 20 years. We realized very soon, not only us, but others also, that thrombolytic therapy really is not the option. And option. So what Vallabh mentioned is exactly what we have gone back to it. We are absolutely not altering anything except for being sure that the personal protection for everybody in the cath lab, including one of the first things to do is be sure that the patient has a mask on and persist with that. My last comment is one of the most humbling experiences I've had in 21 years of doing STEMI interventions, that the thrombotic milieu of a COVID patient presenting with STEMI will bring humility like you have never seen. It is so incredibly difficult and challenging to take care of it. I recently had a 41-year-old male whom we lost. He had presented with the massive, about 12 millimeter ST elevation in the right coronary artery. And I probably made a classic mistake there, that opposed to what I had mentioned to you, I should have taken a picture also of his left, although I think the outcome would have been the same. I struggled for about an hour and a half and finally was able to take care of the right coronary artery after making about 16 passes with the angiojet catheter and putting in a 4.5 millimeter long stent. Finally got an excellent result. The patient was still continuing to have recurrent bouts of VTAC, VFib. Took a look at his left coronary artery, and there was complete thrombosis of the left main, something I have not seen ever in years of doing it. Of course, we lost the patient, and it has only the leftover message which I have is that your skills and your humility will be tested for patients presenting with COVID, and because the thrombotic milieu is so much larger than a regular STEMI patient.
Can I say, I mean, if you,
Thanks.
we've been very silent today. Abdulmajid actually presented few cases like this, similar to what you said, Samir. I mean, he struggled with it. I mean, we was going like 20 times with his aspiration device, not able to breathe. We all faced the same thing during the COVID. As you said, really made you humble to feel, you know, you are learning, you become a student again. I just want to invite you, Samir, to our data from the Gulf, which just recently published in JAHA, American Heart Association. More than 15,000 patients with the STEMI. We looked at six different men and women in the Gulf. And it's very, I would like your comment on that, because I think since you're a leading expert in the field of the STEMI, so we are, you know, women still not getting the guideline, you know, medication and not get revascularization. We found from, this is was one of the largest study in this part of the world. We lost Samir, I don't know where he's going.
Yeah. No, I think it's, yeah, I think there's some sort of a technical issue there. But if I would switch gear to, I mean, I had this question, I don't know if Ronnie is still there, when it comes to the mechanical support in, you know, in cardiogenic shock, like with mechanical complications, do you have any, any insights as, you know, comparing, say, Impella to ECMO or, you know, or other devices? I think we have issues. Yeah, Ronnie is not there. Okay. So intracoronary imaging. I don't know, Abdullah, do you have a special cases where you would still think intracoronary imaging or intracoronary would have a role in the management of STEMI patients?
I mean, the case which really I deliberately showed this bridging, you know, you need to know more about it. You know, especially we missed this case. And then on second occasion, okay, you medical treatment is fine to start with, but you want to know the nature of this bridging. I don't know, Dr. Samir, you want to comment on that? Because what what would be the, I mean, apart from DCB, which I've done for that part.
Yeah.
I don't know.
Samir, we lost you, but intracoronary imaging in the setting of STEMI, either it's IVUS or
So here, let me look, Dr. Shahab, you're exactly right. I mean, there are cases. Dr. Ronnie's case had aspects of it. There are going to be cases where you will need to do elegant interventional cardiology with imaging and all that. But I don't want to lose the message here, which is that this is a procedure which saves lives. This is a procedure in my 2043 consecutive cases or 21 years. I have never used imaging. I have never chased bifurcating lesions. I have never chased total occlusions. I have never looked at any lab. The only thing you need is a EKG, a quick history to know if there is the onset of pain may be longer, but just move them as expediently to the cath lab and open the infarct related vessel. You have to realize there are patients, I have been shocked, who are presenting with the cardiogenic shock, and all it needed was opening the right coronary artery. The patient improves dramatically. Another aspect which I think people get it totally wrong, and I heard that in at least 2 of the presentations today, is a lack of beds. Now, this is something I think we need to take a relook. Most of the time, a patient presenting with STEMI after the cath lab is ready to go home. Okay, you don't need CCU beds. You don't need monitored bed. Majority of them, the aim of everybody in the society, the message has to be to push the system to its limit, to get everybody on the cath lab. Now, I'll tell you exactly what happens in India, which is the absolute interventional cardiology disaster, that they do not let a patient proceed to several hospitals unless the patient makes the payment. That is awful. So look at your system, look at the way a patient presents, push everybody, the EMS, the paramedics, the emergency room. All you need, the best thing which happens to a patient with the STEMI is to open the infarct related vessel.
I think that's a great message, Samir. One of the rules we set is no financial triaging. And the second is, keep it simple. You have a diagnostic ECG, you need to ensure the process is very neat, clean, direct to get the patient to the cath lab. And in the cath lab, make the procedure simple, you restore the flow. That's your objective without a lot of fancy intervention, work unless needed. I don't know if there's any other comments from the panel. The last thing I have here from one of the colleagues, I think in the EMS, and that's a pre-hospital thrombolytic setup. I know, Samir, you had an experience, maybe in some of the countries, although I don't see a lot of space here in UAE because the patients are very close to cath labs. But in remote areas, or distance, or the areas that are far, a pre-hospital thrombolytic strategy, and what kind of setup is needed for such a strategy?
Again, the principles are very similar. If you are going to engage in a methodology, it needs to be outlined. You need to have a very clear idea that patients presenting at hospitals which have a driving distance which is going to be long should be given thrombolytic therapy. Try to use a second or a third generation lytic therapy. Try to give it fast and have an absolute game plan after. I think Dr. Shahab mentioned it so eloquently. After you have given thrombolytic therapy, be absolutely certain to have a game plan to move the patient so that he can have a relook. And almost about 87% of these will require a primary PC also, in addition to the lytic therapy. The problem would be if you've given the lytic therapy and now you have a comfort that, look, everything is okay. okay and you're going to take a chance. No, almost we know 25 to 30% of these patients will continue to have further ongoing ischemia, and you need to have an absolute clear strategy to transfer the patient after lytic therapy.
May I ask Dr. Al-Majid,
Go ahead.
Samir here, you know, as I said at the beginning, Dr. Al-Majid did a great job in terms of, you know, at the level of hospital and, you know, bringing us together. The problem is the symptom to reperfusion. Samir, what you've done in that way, bringing the patient to the hospital as soon as possible.
So everything, Dr. Shehab, I have done. That's why in the presentation which I had, I put the hardest challenge is patient education. The hardest challenge. And towards that, after I figured out this aspect and I understood actually the power of telemedicine, and because of the telemedicine, I learned artificial intelligence, and we've been working on this AI guided patient self-administered device, which the patient can put on the chest, and with the single lead, you have a 97% accuracy of diagnosing self-administered diagnosis of Stemi. I think that if it, you know, we just got the EU approval for it, the FDA trial is at the moment in SEP. I think with the advent of people like Google and Apple into aspects of medicine, there is going to be a further barrage of activity of, you know, immersion of technology into medicine. And particularly, I think for STEMI and stroke management, I think they'll be guided significantly. Somebody else, I think Dr. Wallab had mentioned about a Microsoft-based system. You're going to see more and more of it. Eventually, if there is ever, Dr. Abdul Majid, in your magnificent guidance of the session, if I can leave you with the final message, it is the firm belief that you really want to make a difference in healthcare in your country. Start with STEMI intervention, start with the paramedic system, have a belief with the primary PCI is the way to go. You will save the life. As Dr. Abdullah mentioned, I've known it. I mean, where else in the world do you get an opportunity to use a 30-minute procedure to save the life of a 30-year-old?
Excellent. Thank you so much, Samir. And I mean, we have a lot of questions, but unfortunately, I'm under the pressure of time. I apologize for my colleagues who, you know, who we could not get back to them on the questions, but I need to be respectful to the time of the meeting. Again, Dr. Samir, thank you. Dr. Abdullah Shab, Dr. Kamel, Dr. Corvo, and Dr. Ronnie. Dr. Ronnie got an emergency case and he has to leave earlier. We had a question for him on the support, but wish you him the best. Thank you all for your contribution and your sharing your experience. And I'm sure we'll see you in a future webinar. Before we close, we have an industry sponsored lecture, and it's going to be given by Dr. Wael Abu Shaqqa from Al-Qasimi Hospital. Thank you again, and we'll move to thank you again for the for this webinar, excellent webinar, excellent cases, and we'll move to the industry talk. Thank you, guys. Wael, are you there? Abdullah, I think your presentation is still.
Yes, Dr. Abdul-Majid, I'm here.
I'm okay now. I'm out. My presentation out, yeah?
يعطيك العافية.
دكتور عبد الله ازي حضرتك؟
يلا وائل, we are looking forward to your talk.
Okay.
يعطيك المختصر المفيد.
إن شاء الله. Should I start?
Please go ahead, Dr. Wahid.
Good evening, everyone. Sorry for meeting you.
Make it full screen, please.
Okay, just. Good evening, everyone. And first of all, I want to thank Dr. Abdul Majid and the Emirates Cardiac Society for such an elegant webinar on one of the most important topics in intervention cardiology or medicine totally. Today I'm presenting this talk about the Twilight trial, and I was really happy that Dr. Samir Mehta, he's the PI of this trial. That really is one of the most interesting trials last year. The data was presented in 2020, and maybe that's why it did not change the guidelines still, but I think it will have impact on the guidelines. So what is the impact of Twilight trial on the management of high-risk ACS patients undergoing PCI? So the Twilight trial is using ticagrelor as a single antiplatelet agent after PCI. The study, the logic for this study is they tried balancing the risk and of bleeding on and the risk of ischemia. And we know that this is very tough because bleeding complications, especially major bleedings, carries risk of mortality at the same and this is really very. Can you mute please somebody? Hello.
Please mute your phone, your mic, please.
This study, trials, they reduce the duration of aspirin significantly. The trial was a double-blinded, randomized, placebo-controlled trial that was carried on in 187 sites in 11 countries. It included all PCI patients, but they had an arm for high-risk PCI, and they were treated. The total number of patients was around 9,000 PCI patients enrolled. Around 3,000 or who completed was 2,620. High-risk complex PCI. And after 3 months from the PCI, initial PCI on dual antiplatelets, they stopped the aspirin and in one arm, and in the other arm, they continued aspirin and ticagrelor. So one arm was ticagrelor alone, and the other arm for aspirin and ticagrelor, and continued follow-up for another 12 months. So the total period was 15 months and extended to 18 months observation, another 3 months, so total 18 months observation period. And the inclusion criteria, the patients needed to have one clinical and at least one clinical and at least one angiographic criteria. Clinical criteria: age more than 65, female, gender, troponin positive, ACS, established vascular disease like previous MI or previous documented peripheral arterial disease, or even stroke and diabetes mellitus, or chronic kidney disease with GFR less than 60. Angiographic criteria it was either multivesicular heart disease or target lesion requiring total length of stenting more than 30, thrombotic target lesions, bifurcation lesion with 0.11 at least, and requiring more than 2 stents, or more or equal to 2 stents, or left main disease or proximal LAD disease, or calcified lesions requiring atherectomy. So these are very high risk patients actually, and this was for the high complex PCI arm. And for the demographic data, the two arms was similar, but as we can see, there was a very high incidence or high incidence of diabetes mellitus, around 37%, and chronic kidney disease around 17%, and ACS presentation around 65%. So 65% of these patients, they presented on enrolling as ACS patients. And this is makes them high-risk patients. Primary endpoint was bleeding using the PARC score, and we can see that here there was really a significant difference between the two groups. The group who was ticagrelor alone was 4% bleeding risk, and versus 7.1% in the ticagrelor plus aspirin. And even if they got most of the bleeding scores, the PARC, the TIMI major, GUSTO, and ISTH major, and they're using all these scores, there was the difference was there with reducing risk with using only a single antiplatelet ticagrelor. And secondary endpoints was like MI, death, or stroke. And there was no difference between, there was no increase in MI or stroke or cardiac death in the ticagrelor alone arm. Here is if we go into the secondary endpoints, that we will find that cardiovascular death, MI, or ischemic stroke, there was no difference. All-cause death was less actually with ticagrelor arm alone, and MI, any MI or stroke, there was nothing statistically different, even stent thrombosis. So the take-home message from the whole population is in high-risk patients underwent PCI and were treated with ticagrelor and aspirin for 3 months without any major adverse effects. Antiplatelet strategy with a single agent, ticagrelor, as it is the one who studies, had decreased bleeding substantially and without increasing the ischemic events. We will go very rapidly through the complex PCI group, and we will see that this group is really a complex PCI group. It around 10% has 3 vessel disease treated, more than 3 lesions treated in 30% of the patients. In 50% of the patients, the length of stenting were more than 60 millimeters. In 15%, there was left main stenting, graft, esophagus or lima graft was included in 7% of the case, CTO in 20%, bifurcation in using 2 stent strategy in 10%, and atherectomy in 10%. So these are all our everyday practice with high risk, very complex patients that we need to maintain them for long period on dual antiplatelets. And we can see that concerning the bleeding, there was no difference between the complex PCI group and the all population group concerning the bleeding. The bleeding was less in the same pattern. And the most important is the secondary endpoints, the MIs, stent thrombosis, it was the same. It did not change in this group, specific group. So the risk of bleeding is less in the same pattern, and the ischemic risk is less. In also a very high group is the diabetic patients. We see the same pattern again. In diabetic patients, there was less bleeding compared to the whole study group in the same pattern like the other, the whole study group. And the same reduction in bleeding, and with no increased risk, or actually there was decreased risk here than of ischemic events. So in conclusion, that in these two special groups, there was the same reduction of bleeding and reduction of ischemic events was noted, even with a single antiplatelet after 3 months, of PCI. I will go through this rapidly. These are how you can identify the patients who are at risk for bleeding. As you all know, we have the precise DAP risk score, and if the score is more than 20 or 25, it's very high risk of bleeding. And but this is a more recent bleeding score by the European Society of Cardiology, and they stated that severe chronic kidney disease, hemoglobin less than 11, or spontaneous bleeding in the last 6 months, or anticipated long-term use of OWAX, moderate severe baseline thrombocytopenia with platelet count less than 100, chronic bleeding diathesis, or liver cirrhosis, active malignancy except skin malignancy, or previous intracranial hemorrhage or stroke, or AV malformation, and recent surgery in the last 30 days. In these patients who are, you think that you have high risk of bleeding, you might consider, or you should consider using ticagrelor over other antiplatelets that we are using. So if you need to drop aspirin, it's easier. So my take-home message, for the sake of the time, because we cross the time, it's although the use of single antiplatelet lesion up till now is not indicated in high-risk patient post-PCI by any guidelines, still need in our everyday practice, we need to sometimes to drop one of the antiplatelets due to bleeding complications, and this is not an unfrequent practice in the care of our patients. The use of TULITE data give us more confidence to choose ticagrelor in such conditions, especially in patients with high ischemic risk. It seems rational that to start patients with ticagrelor if they are considered high risk of bleeding, to avoid switching from an antiplatelet to another antiplatelet and reloading, especially if GI bleeding. Although STEMI patient was excluded from this study, But I don't think it's wrong to, if you have a patient with recent STEMI less than 3 months or even less, and he had a major bleeding, and you have to drop aspirin, to think about using ticagrelor. Although it is better to be proved by conducting a randomized double-blind trial to prove this. And thank you, everyone, and I hope great night for everyone.
Mashkoor, Dr. Wael. Thank you so much. And you know, I just got one thing in the Q&A, which I don't know if the person who was asking, talking about the ticagrelor loading dose as a 40 milligram, and I think there's a mix up there. The loading dose we give is 180 milligram of ticagrelor for in patients with acute coronary syndrome. So just to highlight that point. The other point, Wael, is the high risk bleeding or the risk bleed in Twilight. What was it in this study? What risk did they use? What bleeding risk did they use?
Mainly the PARC bleeding score.
PARC, yeah. So we need to be familiar. Managing antiplatelet and anticoagulants usually is tricky, and it's very important to familiarize yourself with with these antiplatelets. The risk of thrombosis, which depends on a lot of factors. Either it's patient's factors or angiographic factors or comorbidities, and also the bleeding risk on the other side, and then decide what is the right formula for the patients, in terms of dual antiplatelet, or if there's a need for anticoagulation. So this field is very complex, and it's very important to understand. And I think Dr. Wael, you highlighted this study, this important study that that give us a lot of insight when it comes to managing patients post ACS and post PCI. Antiplatelet treatment. I think just because of the time, we need to come to a closure. Again, I would like to thank you and thank the panelists in this webinar, Dr. Samir Mehta, Dr. Kamil, Dr. Abdullah and Shihab, Dr. Ronnie and Dr. Kobo. All thank you so much for this very useful and interactive webinar. Have a good night.
Thank you, Dr. Magid. Have a great night.
Thank you, everyone. Bye.
Thank you, everyone.
Thank you. Thank you.